Welcome to our next session entitled, Why Did I Get IBD? What We Know and Don't Know, featuring Dr. Linda Annie Fegans with UT Medical School and Dr. Apurva Trivedi with Capital Gastro. Annie Fegans is an associate professor of medicine in the Division of Gastroenterology and Hepatology at the University of Texas at Austin Dell Medical School, and the director of the Center for Inflammatory Bowel Diseases at UT Austin Dell Medical School. Dr. Fegans attended medical school at Baylor College of Medicine in Houston, and she then trained in both internal medicine and gastroenterology at UT Southwestern Medical Center in Dallas, Texas. She was an associate professor of medicine at UT Southwestern and directed the IBD program at the VA North Texas Healthcare System from 2008 until 2019. When she then joined the Dell Medical School in July 2019. Dr. Fegans' IBD-focused practice here in Austin is at UT Health Austin, located on the UT campus near the medical school. Her clinical practice focuses on all aspects of caring for patients with IBD, including the latest medical therapies, diet and nutrition, preventative care, and access to social workers and mental health professionals as needed. She is also heavily involved in research and is working on opening clinical trials for patients interested in participating in research studies and or those failing conventional therapies. Dr. Fegans has also been involved in the Crohn's and Colitis Foundation nationally since 2008. Apurva Trivedi is a board-certified gastroenterologist and internal medicine physician at Capital Gastro. Dr. Trivedi has expertise in the management of inflammatory bowel disease, Crohn's disease, ulcerative colitis, and C. diff. After earning his undergraduate degree from prestigious Duke University in Durham, North Carolina, Dr. Trivedi earned his medical degree at the University of South Alabama College of Medicine in Mobile, Alabama. He then went on to complete his internal medicine residency at Wake Forest School of Medicine in Winston-Salem, North Carolina. Dr. Trivedi completed his fellowship in gastroenterology in the Hepatology Scholars Program at the University of Maryland Medical Center and the VA Medical Center in Baltimore and National Institutes of Health Clinical Center in Bethesda, Maryland. He enjoys sharing his skills and knowledge and has experience teaching medical students, residents, and fellows at Texas A&M Health Science Center in Bryan, Texas. Outside of the office, Dr. Trivedi enjoys spending time at the lakes and rivers around Georgetown and Austin, reading and meditating. Thank you once again to our sponsors, Paragon Infusion Center, Gilead, and Takeda. Again, without your support, this program would not be possible.
Okay, well, let me start by saying thank you to Alicia and thank you to the CCFA for the invitation to be able to be a part of this session today. As Alicia mentioned, Dr. Trivedi and I have been given the task of talking about what causes inflammatory bowel disease. So I will start us off and then Dr. Trivedi will finish up the session. So again, the focus of this session is to discuss what causes inflammatory bowel disease. So in short, the answer is that we don't know the exact cause of IBD. But we do know that a number of things seem to play in. We know that IBD is an abnormal immune response to the usual intestinal flora or microbiota in a susceptible host, meaning that the body turns on inflammation for some reason that we don't clearly understand why, and then it doesn't turn it off the way it's supposed to. And we know that a number of things can play into this. First one being genetics. You'll hear more about this later from Dr. Trivedi, but in short, we know that a family history of IBD as well as certain genes can predispose to getting IBD. However, this only accounts for a small portion of patients with IBD. We also know that the environment, as well as each person's unique immune system, play into getting IBD. And I'll be talking about a number of these environmental factors in my portion of the session. So just to kind of get us started, I want to talk about a few of the bigger risk factors that we do know about for IBD. Certainly age is a risk factor. We know that IBD can occur at any age, but most commonly we see it diagnosed in young patients. Ethnicity, we do know that IBD can affect persons of any ethnic group, but historically we've thought of it more commonly in whites and those of Jewish descent. However, more recently, we've been seeing this disease become more common across all ethnicities. As we talk about these environmental factors today, you'll see that some of these changes in the environment may be playing into that. Family history is certainly a risk factor, like we already mentioned. Smoking is a risk factor, and this is particularly for Crohn's disease. And then lastly, where you live seems to be a risk factor. And this seems to be more common in persons who live in more urban and industrialized countries. So with that said, I wanted to show this map to kind of start out with. This is what's called a heat map by the way that it's colored. It colors each of the individual countries. And what it's showing is the prevalence or the numbers of cases of persons with inflammatory bowel disease. So because this is a heat map, the colder colors, meaning the blue colors, are the places or countries that have lower rates of inflammatory bowel disease, while the hot colors or the reds are those that have the highest rates. And as I just mentioned on the last slide, the more developed and industrialized countries seem to have the highest rates of inflammatory bowel disease, as you can see very easily just looking at this map. And that particularly includes the United States and Europe. In all, there are estimated to be 6.8 million cases of inflammatory bowel disease around the world. And in the US, that's about 3 million people, and that accounts for about 1.3% of our population being diagnosed with IBD. So with that in mind, I wanted to start by showing a couple studies about living in these sorts of areas like the United States or Europe, where we see the highest rates of inflammatory bowel disease. So the first is a study from Spain, where they looked at patients who had immigrated out of Spain to either Europe or Latin America and compared rates of developing IBD between these two groups. Interestingly, they found that patients who immigrated to Europe, which is considered to be more industrialized than Latin America, these folks were about 2 times more likely to develop IBD than those that moved to Latin America. In a second study in Canada, they looked at people who were immigrating into Canada from other places. And they compared the rates of developing IBD between the people who already lived in Canada and the new immigrants. And they found that the risk of IBD was much lower in these immigrants as compared to non-immigrants, about 65% lower risk. However, when they looked at the children of these immigrants who grew up in Canada, they had the same risk for developing IBD as the people who were not immigrants, basically meaning that these children had lost whatever protection it was that their parents had brought with them from another country. So what's different about being in a more industrialized or Western society that might increase our risk for inflammatory bowel disease? So this is where all the studies come in that have tried to identify what it is in our environment that may be predisposing people to IBD. And I've listed out a variety of things here that have been hypothesized and studied that they've been trying to understand how these things might play in. We don't completely understand a lot of these, but we have a lot of data that's kind of given us a little bit of some ideas to try to explain some of these things. So at this point, for the rest of the session, I'm going to be talking about a number of these different things. Particularly, I'll focus on the first 3, and then Dr. Trivedi is going to take over and talk about the rest of them. All right, so let's start with diet. So patients quite commonly believe that diet plays a role in their developing inflammatory bowel disease. There have been a number of survey studies that have been done that report anywhere from 16 to 48% of patients believing that their diet plays into IBD. So I'm about to show y'all a number of studies regarding the possible role of diet in developing IBD that substantiate these patients' beliefs, but it's important to remember that at present, there's really no definitive evidence that diet causes IBD. So basically most of what I'm going to show you is just quite suggestive, and we still have a lot to learn. So with that said, some of the components of the Western diet that are thought to play into this higher risk of inflammatory bowel disease include diets with a high meat content, high fat, low fiber, and including additives like emulsifiers. And so I'll touch on each one of these. So what's the idea behind meat? Let's start there. So a possible theory about why meat may be harmful for the gut in inflammatory bowel disease is that the fermentation of sulfur amino acids, which are in meat, by the bacteria in the gut, can produce hydrogen sulfide. And it's thought that this may weaken the lining of the gut, like making the gut more leaky, or increasing basically the vulnerability of the gut lining to bugs inside the gut and predisposing to inflammation. There have been a number of studies in both ulcerative colitis and Crohn's disease that have looked retrospectively, meaning they've looked back in time, and they've shown that there's a possible increased risk for patients who have consumed higher amounts of meat in their diet in regards to developing UC and Crohn's disease. And they've estimated these risks to be anywhere between 1.8-fold higher risk to a 2.5-fold higher risk. However, every single study that's looked at this hasn't been consistent. So some of them have shown this association and some of them haven't. Most recently, there was an interesting study that came out last year. This was a prospective study that was performed using a large internet cohort of patients through the CCFA that was able to identify patients first with Crohn's disease and these patients who were in remission at baseline. And these patients were meat eaters. They then took this group of patients, randomized them to either reducing their red meat consumption to no more than once a month, or to continue their usual meat consumption where they were required to eat at least twice a week meat. They then followed these patients out over the next year to see who had a flare-up of their disease. And what you can see when you look at the graph is that there was really no difference in the rates of flare for patients in regards to how much meat they were eating. So what can we learn from this? Well, at least in the way that this study was done, we can learn that if you were a meat eater and you have Crohn's disease and you're in remission, if you reduce your consumption of red meat or processed meats to no more than once a month, it doesn't seem to reduce your risk of flare. However, keep in mind, this didn't limit the other types of meat like chicken and fish and only really focused on red and processed meats. So there's certainly a lot of ways that you could look at this question about meat in the diet. So how about fat in the diet? So what's the theory behind fat? So fats, especially polyunsaturated fatty acids, which could be called PUFAs, are thought to be linked to the development of IBD, but it seems to be specifically about the ratio of the kinds of PUFAs that are out there. So there are two big groups. We call them omega-6 polyunsaturated fatty acids and omega-3s. And it's thought that the omega-6s are the bad ones, the ones that are thought to be pro-inflammatory, while the omega-3s are thought to be protective or anti-inflammatory. And again, it's about this ratio. So in animal studies where they fed animals high-fat diets, it's been shown that these high-fat diets can disrupt the gut barrier function and promote inflammation. And in large human studies where they've looked back over people's diets and over time, they've seen that in folks who have eaten higher ratios of omega-6 to omega-3 fatty acids, that these people had a higher risk of developing ulcerative colitis and Crohn's disease later on. So this is a recent study that evaluated fat in the diet in a prospective way. So it was a small study. They only enrolled 17 patients, and it was all just ulcerative colitis patients who were in remission. And they randomized them to either eating a low-fat diet, where 10% of their calories came from fat, or a standard diet, which they decided was 35 to 40% fat. And they did this for 4 weeks. And the endpoints that they were looking at, because these patients didn't have active disease to begin with, they were actually just looking at overall quality of life, meaning generally how well people felt on these diets. And it was actually interesting because with both diets that people got randomized, they actually felt better on both of them. And it ended up when they went back and compared it to their baseline diets, that both of these diets ended up being healthier than these patients' baseline diets. And everyone felt better. But interestingly, when they specifically compared those who were on the standard fat diet versus the low fat diet, and they looked at some markers of inflammation, specifically they looked at things like fetocalcitonin and C-reactive protein, which we use in the clinic, and then they looked at some experimental things like serum amyloid A. It looked like these markers got improved as patients ate actually lower fat. So what can we take away from this? So certainly we can say that eating healthier certainly seems to make people feel better, and that it looks like maybe a low-fat diet might improve some of the markers of inflammation, but we certainly need bigger trials to know this more for sure and to look at it actually in patients even more so with active disease. So let's talk a little bit now about emulsifiers. So what is an emulsifier and what does it do? So emulsifiers are food additives, and these additives are thought to be pro-inflammatory. So what are they used for? They're commonly used to give food products a smooth texture. They prevent separation, like you can see in this picture, and they extend the shelf life of products. So what are some of the things that you could look for when you read a label to look for emulsifiers? Things like carrageenan, carboxymethylcellulose, and polysorbate 80. So at this point, we don't have any human data in regards to emulsifiers in the diet and outcomes in that regard, but we do have some animal studies that are interesting and provoking. Animal studies have shown that these emulsifiers actually exert effects on the gut microbiota, and they seem to decrease diversity of the bugs that are present in the gut. And we typically think of more diversity as healthier, so certainly decreasing diversity is not a good thing. They've also seen that emulsifiers in the diet seems to promote particularly bacteria that are pro-inflammatory. And they've even seen in some of the animal models that these emulsifiers seem to promote ulceration within the gut. So now let's talk a little bit about fiber. So fiber, as probably many of you are aware of, has been shown to have numerous health benefits. It's been shown to lower the risk of heart disease, colon cancer, and infections in people in general. And so the guidelines for everyone actually recommend that all persons should be eating a high fiber diet. And that means 25 grams per day for women and 38 grams per day for men. However, unfortunately, the average American actually doesn't eat anywhere near that amount of fiber in their diet, and it's been found in numbers of studies to be around 14 grams per day. There's actually a few studies looking at fiber intake in IBD patients, where they actually found that that number was even lower, anywhere between 9 to 11 grams per day on average. So why would fiber even be good in inflammatory bowel disease? So the idea is that fiber actually promotes fiber-loving bugs in the gut. So the more fiber you eat, the more fiber the bugs have to eat, and they can grow. This fiber is there, and it helps build up the protective lining of the gut. And when the fiber is broken down by the gut bugs, they actually produce these things called short-chain fatty acids that are actually fuel for some of the cells within the gut. So here's a little bit of data that supports this notion that fiber can reduce the incidence of getting IBD. So this is a really big study that was done called the Nurses' Health Study. And it followed over 170,000 women for several decades. And along the way, these women were asked periodically about what they were eating, and that data was reported. And then this research group went back and asked, after about 26 years of follow-up, at the point that they went back and looked at this data, and they asked the question, how many patients had developed inflammatory bowel disease over this time period, and what were they eating? And when they looked at fiber in the diet, they found that the women who had high fiber diets, and that was an average of 24 grams per day, as compared to women who ate low fiber diets, and that was an average of 13 grams per day, actually had a 40% reduced risk of developing Crohn's disease as compared to the high fiber versus the low fiber. Interestingly, when they looked at the same question and just looked at the patients with ulcerative colitis, they saw a similar trend, but they found that that risk reduction didn't end up being statistically significant. So how can we put all this diet information together? So the basic idea is that diet can affect the gut, and specifically the microbiome of the gut, in different ways to potentially change the risk for inflammatory bowel disease. Fiber seems to be beneficial. Some of the things it helps build up the mucus layer in the gut, and it has byproducts producing fuels for the gut, which are thought to be protective from inflammation. On the other hand, a diet high in fat and meat may be harmful by making the gut more leaky or causing other changes in the immune system, or even producing those toxic hydrogen sulfide that we discussed, that overall these things may increase the risk of inflammation. So with all that said, there's still a lot we don't know about diet. All of these studies are certainly suggestive that dietary habits may be altering our risk for inflammatory bowel disease, but we still don't know if changing our behaviors will clearly reduce that risk, or if there may be other things also playing in. We also don't know if changing our diet after being diagnosed with inflammatory bowel disease will reduce the disease severity or how soon someone has a flare. There's certainly a lot of interest in diet currently, and there are quite a number of studies and trials ongoing looking at various diet combinations of trying to put together all these different pieces of the food that we've been talking about. Some of the diets that they're looking at include the specific carbohydrate diet, as well as the Mediterranean diet. And hopefully within the next few years, we'll have data from these studies to help guide us a little bit more. So besides diet, there are other things in our environment that may have effects on the microbiome as well. And certainly talking about diet, you can see that a lot of it plays into the microbiome. And so I'll cover a couple more of these before I hand it over. So first, let's talk a little bit about breastfeeding. So certainly the popularity of breastfeeding has waxed and waned over time. What we mean here in regards to breastfeeding is that how does it affect your risk if you were breastfed? And so what studies have shown is pretty consistently there seems to be a protective effect of having been breastfed, and they average it to be about a twofold decreased risk if you were breastfed of developing ulcerative colitis and Crohn's disease. It's interesting that they've actually looked at other diseases with this same question and found similar results, and those included diseases like asthma and type 1 diabetes, which are also immune mediated. So why would this even play in? So here are some of the theories that why breastfeeding could be effective. One, breastfeeding may help babies develop what is called immune tolerance. So there are a ton of things in our body that we get exposed to in the environment, both externally and through what we eat. And our immune system has to learn what to respond to and what not to respond to. Certainly we want it to respond to an infection that we want to get rid of, but we don't want it to respond to all the different foods that we eat that we need to nourish our bodies. And it's thought that breastfeeding may help this process along. Also, specifically, we know that within breast milk, there are antibodies from mom, and these may also be playing into this immune tolerance. Lastly, and probably very importantly, is the process, during the process of breastfeeding, is that it probably affects the gut microbiome and likely helps promote the development of beneficial species within the gut that help produce this protective environment. So along a similar line is the idea of being exposed to antibiotics. And the effects of being exposed to antibiotics at a young age has been studied. Now, initially they looked at ulcerative colitis, and they did not find that there was any effect of developing ulcerative colitis in regards to antibiotic exposure, but they did find some risk in regards to Crohn's disease. They found that there was an increased risk for Crohn's, and it seems to be in a dose-dependent manner. And when we see studies where things are dose-dependent, that make us think that it's a little bit more likely that this is a real effect that we're seeing, meaning the more you're exposed, the more risk you have. What they found in these early antibiotic exposure studies, that in children who were under the age of 1 year, that if they were exposed to antibiotics at that age, they had a 5-fold increased risk of developing Crohn's disease. And those that were exposed to antibiotics later in childhood had about a 1.5-fold increased risk of developing Crohn's. So again, the mechanism here, why would this increase your risk? It may have to do with some of those similar things that we were just talking about in regards to breastfeeding. It may disrupt the formation of a healthy microbiome, or it may disrupt the formation of that immune tolerance to all the bugs in the gut or the things that we're exposed to. And so with that said, at this point, I'm going to hand it over to Dr. Trivedi to continue on with talking about some of these other topics.
Thank you, Dr. Fegans. That was super interesting. I did have some questions come up here before we get to Dr. Trivedi's presentation. I hear leaky gut a lot. Like this comes up as something that happens to a lot of people. Can you explain what exactly that is, and how might somebody know if this is something they're experiencing?
I don't think it's something that people would know that they're experiencing, but it's something that from kind of a research side of things and trying to understand why people get inflammatory bowel disease or have other bowel diseases. Basically what it means is, that so there's the lining of the gut, and then typically there's a nice thick mucus layer over the lining of the gut that helps protect the gut. So you don't want the gut to be continually exposed to all the things outside the environment. And so that basically if things help degrade that mucus layer, that allows more exposure, and we think that more exposure to these different antigens or whatever bugs that they're being exposed to, that could induce more inflammation or more response from the body to these things that it's seeing. So certainly that mucus layer plays in, and then sometimes we'll talk about leakiness in regards to just how close all the little cells are. And sometimes when there's a lot of inflammation, the cells aren't quite as close together, and the little junction that should hold them together aren't quite as tight. And again, those things kind of coming through the layer exposes more of the inside of the gut to things that would potentially produce more inflammation. Does that kind of make sense?
It does. Yeah, it does. Um, when you're talking about, so when in talking about fats and in having kind of a low fat diet, is there a difference, and maybe the research doesn't necessarily show this, so tell me if that's the case, but is there a difference between things like good fat? So like avocados are sort of, they're fatty, but that's a good fat according to a lot of dietitians. Was there a difference between a diet that's high in that sort of good fat versus the sort of poly unsaturated fats, the sort of, too many French fries versus too many avocados?
Yeah, I mean, I think that's you're getting kind of at basically what I was saying. There's those omega 3s and
Yep.
the omega 6 fatty acids, and it has to do with basically the ratio of the good fats to the bad fats.
Okay.
And the risk that they found, I mean, again, what they were looking at specifically was the risk of developing inflammatory bowel disease, not necessarily making it more active, or that kind of two different questions. But
Mm-hmm.
regards to the risk of developing inflammatory bowel disease, they found that ratio where there were more of the bad fats, that seemed to be what was the higher risk, and the other way around was a reduction in risk.
Okay. This is going to be a question for patients who already have Crohn's disease. So not necessarily a why are you getting it, but if, in the question about fiber and sort of, people who are in consuming more fiber tending to maybe, be a little healthier. A lot of our folks with Crohn's disease struggle to get fiber because it's hard on their, especially when they're in flares, it's hard on their system. So what do you recommend to your patients if they're trying to increase the amount of fiber in their diet without reacting badly to it?
I mean, I guess everyone's going to be a little bit different. You have to kind of experiment with different foods. Certainly, you want to introduce fiber slowly into the diet. We know that eating a lot of fiber all at once can make people feel, even without IBD, people will feel not good. I mean, it'll make you bloated and feel really full. And so certainly, as you introduce fiber into the diet, you want to do it slowly. I think it's interesting because it's kind of one of these old dogmas that we've been trying to get away from, which is telling people not to eat fiber when they have Crohn's and ulcerative colitis. Certainly, it seems to help during flares sometimes, or at least anecdotally. I don't know that we have data for it, but anecdotally. But we certainly don't want people to do that long term, just given all these health benefits of fiber. So I think as far as things that they could do, again, adding it back slowly and trying different things to figure out which ones you can tolerate and which ones you can't. And certainly cooking the foods with fiber is helpful. Eating things raw is certainly going to be more difficult than cooking the fibers. So that's certainly one of the ways to start as well, and then just kind of slowly taking those steps to try to get towards enough fiber in the diet.
Yeah. And all of this is so interesting because, like you said, so much of your microbiome is sort of developed, in times when you don't have any control of it. So when you're breastfed or when you're a kid and they give you antibiotics, and frankly, if you're a child of the 70s or 80s, you got a lot of antibiotics for everything, it seems like. So is there anything you can do to try to influence that? I mean, if you weren't breastfed and you did take lots of you had lots of ear infections when you were a kid, so you got lots of antibiotics. Are there things you can do now to try to ameliorate kind of what was done in the past?
Yeah, and I think that's the question, and that we don't really know the answer to. How much of our microbiome is really set at an early age, and how much can we change it now? I mean, they've certainly done studies where they've looked at people changing their diets or getting exposed to various things, and we know that the microbiome reacts actually very quickly. A diet change from, say, eating a plant-based diet to a meat diet, you'll see changes within a few days within the microbiome when they've done studies looking at that. But whether those changes will be long-term, or you'll go back to some of these influences from the beginning that have kind of set some of these things in this way, I don't think we know that quite as well. I think the answer is that we don't quite know yet. There's so much we don't know about the microbiome.
Yeah, it's so fascinating.
But there's all these diet studies that are going on, and we're hoping to be starting some at UT Austin as well. So hopefully getting involved in these will help us figure out ways to get people treated, and to augment their treatment, if there's a way to do it with diet, or at least getting people to eat healthier as much as we can, I think is a great thing.
Right, for sure. And I think diet is certainly one of the hottest topics we have kind of in our IBD world, because it is something patients can do that's on their own. Like it doesn't have to be prescribed to them. It's something they can control. And so, it's the first line kind of thing they can do. So I think, yeah, the more we know, the better it's going to be. And I think the more people will feel like they have control over their disease and can take charge a little bit more.
Absolutely. Absolutely. I feel that the, integration of a dietitian into your care is so important. And that's something that we're doing in our clinic. And, I feel like that's something everybody can meet with a dietitian and try to figure out what works for them and what doesn't work for them, to make sure that you're getting all the nutrition that you need. And again, trying to optimize these things if you need.
Yeah. Well, and I think more and more practices are like yours, where they're really thinking about the patient as a whole. So not just their small intestine or their large intestine and their GI tract. They're saying, GI tract is attached to the larger whole. So bringing in dietitians and mental health, folks and social workers and things like that to really treat the whole patient, which is really wonderful to see.
Yeah, exactly.
That's great. I have one final question for you, and you can tell me if this goes too far off the rails, because this is a big topic, but how does something like fecal matter transplant really start to influence that microbiome? What do we know about that? Because I know there's still a lot we don't know about fecal matter transplant.
Yeah, I think we're still learning a lot about that right now. We know the one clinical indication where we know that fecal transplants work are patients who are infected with an infection called C. difficile.
Mm-hmm.
And absolutely, when those folks get fecal transplants, it really works really well. There's certainly been a lot of interest in looking at it in inflammatory bowel disease. It's at this point, I think, those are things we're only using in clinical trials, and they're not quite ready to know how to do it. And part of the problem is, exactly how do you do it? Everyone does these transplants a little bit different. You put it in from the top, you put it in from the bottom, you take it as a pill, is it a slurry, all these different ways that and so many different nuances and people getting different results, trying to figure out what made the difference and how's the best way to do it. There's probably something to it, but at this point it's not ready for prime time.
Yeah. Well, it's nice to know that it's a good option for C. diff, because
Yes.
I know that is a very hard diagnosis for a lot of folks, and this seems to be a relatively easy way to treat it, and something that you're not taking antibiotics again or something like that. So that's cool. Well, Dr. Figgins, thank you so much. Any other final thoughts? I know we've got Dr. Trivedi is going to kind of cover some of the other stuff here coming up. So I know we'll have time for more questions later too, but any other final thoughts?
I think that you had some great questions. I appreciate it.
No problem. All right. Well, thank you so much. We're going to turn it over to Dr. Trivedi now.
Hi, thanks for having me, Alicia. So my name is Apurva Trivedi. I'm a physician in Austin, Texas with Capital Gastro, and I'm going to talk a little bit more about some environmental factors and genetics involved in development of inflammatory bowel disease. Next slide. Okay, so this is a Venn diagram that kind of encompasses our current understanding of inflammatory bowel disease. So inflammatory bowel disease, including Crohn's disease and ulcerative colitis. These are chronic, relapsing inflammatory conditions of the GI tract without any clear infectious or environmental cause, but there are triggers that seem to activate Crohn's disease or ulcerative colitis in a genetically susceptible individual. So this is what we call multifactorial, meaning that there's multiple causes. There's no one single underlying cause. There is a genetic predisposition in certain individuals. There are certain shifts in the intestinal flora or the bacteria in the gastrointestinal tract. And there are likely environmental exposures that lead to a faulty response in different parts of the immune system. And this involves an interplay between all these areas. Okay, so let's go to the next slide. So when we think about what the gastrointestinal tract has to do, it has to process food that comes into the gut, and it also has to balance out trillions of bacteria, fungus, and viruses that are constantly in contact with the gastrointestinal tract at what we call the mucosal level. And that interaction is generally a very balanced interaction that allows for majority of bacteria to be tolerated by the immune system. The genetic factors, though, that can be at play are genes that interact with genes that determine how the immune system interacts with all these bacterial products and food products. So in Crohn's and ulcerative colitis, there's an intense recruitment of immune cells with a prolonged survival of those immune cells that causes damage with ulcerations and bleeding and loss of the intestinal lining. But in what we want to talk about here is the genetic side of things. Genetics don't seem to play 100% a role in explaining what causes inflammatory bowel disease. So there's a complex interplay that we'll talk about a little bit. Next slide. So there are factors that we can identify that are in general populations that seem to be risk factors for developing Crohn's disease and ulcerative colitis. For one, women tend to get Crohn's disease more often than men, and by 20 or 30%. And for another, we see that in industrialized countries and westernized countries, we have much higher rates of Crohn's disease and ulcerative colitis. So for example, in India, there's the lowest rate of inflammatory bowel disease in the South Asian population, but those South Asians, once they move to North America, United States, Canada, or the United Kingdom, they have increased risk of ulcerative colitis compared to when they were living in India. So westernization of lifestyle and industrialization seems to play a factor. In different ethnic groups, there seems to be a higher rate of inflammatory bowel disease. So whites, Caucasian race have stronger family history of inflammatory bowel disease and more rates of colorectal cancer. And there is similar disease activity across all groups, but it seems to be that ulcerative colitis develops in the first generation of individuals moving from a developing country to the westernized country. And then the risk of Crohn's disease develops as multiple generations have been living in the new environment. Currently, we think that Asians, Mexican Americans, and African Americans have lower rates of Crohn's disease than Caucasians, but again, ulcerative colitis rates are higher in those populations that have recently become westernized. Next slide. So one way to think about genetics is to think about families. So genetics really are best demonstrated in situations where we have twins. So there's two different types of twins. There's a monozygotic twin or identical twins, and there's dizygotic twins or fraternal twins. So monozygotic twins, identical twins, have identical genetics for the most part. And in most of these families, you're going to be raising children who are exposed to similar environmental exposures. So their diet's going to be similar, their antibiotic exposure is going to be similar. They'll likely have the same infections growing up together. And so there have been a number of studies done primarily in Europe where they have longer term data that show that in monozygotic situations, so when you have identical twin pairs, not each of the twins will develop Crohn's disease. So at most, 50% of the twin pairs will have Crohn's disease if one of them has it. So a minority of these cases you can explain as genetically driven. And in ulcerative colitis, it's much less clear. When you have two twins, if one twin has ulcerative colitis, the likelihood of the other having ulcerative colitis is only about 14%. When you go to fraternal twins, which is this dizygotic twin pair, they have different genetics, so they're like siblings. They'll have as much shared genetic material as any two brothers or sisters, but they do share the same birth environment in utero, and so they'll be growing up in the same households at the same age. And that environmental exposure still does not account for an explanation for why they would develop Crohn's disease in no more than 8%, and in very few ulcerative colitis cases. So what we find is that there is a higher rate of inflammatory bowel disease in individuals who have a family history of inflammatory bowel disease, and it's highest amongst first-degree family members. So a positive family history of inflammatory bowel disease does confer about a 10-fold increased risk for you developing inflammatory bowel disease. However, that doesn't explain, the genetics of that doesn't explain all of it. So concordance is this idea that two twins should develop the disease together. And what we see is that we would expect in a genetically identical situation, if genetics was the whole story, that concordance would be much higher than this 50%. And these numbers come from a British study of about 250 twin pairs and a Swedish and Danish study of similar numbers. Next slide. So what we do learn from these genetic studies is that although there is a genetic basis for inflammatory bowel disease and there's familial clustering inflammatory bowel disease, when we look at the discordant pairs, when there's one twin who has Crohn's or ulcerative colitis and the other doesn't, and we take a detailed history, we can try to identify factors that predispose to development of Crohn's disease in the affected individual. So what was done in this British group was they looked at these 250 twin pairs. Only 28 pairs of twins had concordance, while 220 twin pairs were discordant, meaning one twin was affected and the other twin was not. So in these pairs where there is a difference between these two twins, they looked back and asked the question, what could have explained the development of Crohn's disease? Well, in the UK, before the 1980s, a vaccination for mumps was not widely available. So in their study, exposure development of symptomatic mumps infection was linked to a higher rate of Crohn's disease. And so there's one infection that may be a trigger in some of these individuals. The other risk factors that we saw in this study was smoking. So smoking in Crohn's disease has been linked to higher rates of disease and worse disease outcomes, and this was true in this study. Individuals who were smokers were 4 times as likely to develop Crohn's disease than their twin who was not a smoker. And oral contraceptive pills or birth control use was also associated with an increased risk of Crohn's disease in the individual who used oral contraceptive pills. This was about a 4-time increased risk for those who did not. The other things that they looked at this study to try to identify as possible associations that did not pan out were infections with measles, chickenpox, development of pneumonia, antibiotic use. None of these factors were associated with development of Crohn's disease. Appendectomy, tonsillectomy, coffee use, tea use, playing sports, having asthma, hay fever, none of these factors were clearly associated with development of Crohn's disease. There was another analysis done on the same data set, and they were able to pinpoint prior illness, being more unwell and having more gastroenteritis prior to a diagnosis of Crohn's disease, and possibly having more animal exposure, such as pets, had an impact on increasing the risk of Crohn's disease. So next slide. So another idea that has been explored is infections. So we have seen that Crohn's disease can be activated at the time of an infection. And pro-inflammatory bacteria or bacteria that seem to cause activation of Crohn's disease include some of the species listed here. So Bacteroides, Enterococcus, specifically pathogenic E. coli strains, Listeria, Yersinia, and Clostridium difficile. These infections have been identified in patients with Crohn's disease and seem to be, when the infection develops, they can be activators for individuals who are predisposed to developing Crohn's to go on to develop the disease. We have found that certain bacteria may be protective. So lactobacillus, bifidobacteria, and non-pathogenic E. coli may actually help stabilize the immune system in the gut and prevent development of ulcerative colitis or Crohn's disease. One infection that has been studied extensively that has been clearly shown to not be associated with the development of Crohn's disease is a bacteria called Mycobacterium paratuberculosis. This may be something that you've heard about and was studied pretty extensively, and very aggressive antibiotic regimens were used to try to eradicate this bacteria. And there was no clear association with this bacteria causing Crohn's disease. However, there have been isolation of this bacteria in individuals with Crohn's disease, but it did not seem to be the underlying cause, and getting rid of it did not seem to improve the underlying Crohn's disease. So when we look at the interplay in the gut, again, there are multiple factors that are interacting with the immune system. We have bacteria, we have food sources, and the underlying genetics have a role to play there as well. Next slide. So there has been very extensive research performed over the last 20 years in trying to identify which specific genes in an individual might increase risk for Crohn's disease. So we can see in those twin studies that there is probably some genetic association. And so when we do the twin studies, it gives us a hint that there may be an underlying single gene. But what we found is that, in fact, there are upwards of 200 genes that seem to confer an increased risk for Crohn's disease. So Crohn's disease and ulcerative colitis have been at the forefront of complex genetics research. And as early as 2001, the gene NOD2 was isolated and felt to have an increased risk when you have a mutation in this gene to increase the risk for developing Crohn's disease. Since that time, again, upwards of 100 genes for Crohn's disease and 100 genes for ulcerative colitis have been identified that seem to, when mutated, cause an increased risk for development of these diseases. What we know about these genetic factors is that they play roles in the way our immune system develops and the way our immune system interacts with bacterial trafficking at the level of the intestinal lining. So this balance between allowing good bacteria that should be present in the intestinal tract and allowing the immune system to not overreact to those versus identifying pathogenic or infectious bacteria and being an aggressive immune system in those situations, that balance can be disordered in Crohn's and ulcerative colitis. And it seems that the bulk of the genes that are mutated in these studies are involved in signaling how the immune system interacts with these bacteria. So the insights that we've gained from understanding these genetic abnormalities help us identify certain signaling pathways that are important for therapeutics. So, for example, the IL-23 signaling pathway has been identified to be important in Crohn's disease and ulcerative colitis. And that specific pathway has led to the development of immunomodulators that target that pathway that are available now. And we hope that as new genetic loci are identified with these studies, we are able to develop additional new drugs. Next slide. So one other factor that genetics can drive is the severity of disease. So with Crohn's disease, ulcerative colitis, it's difficult to know who's going to have a more severe course and who's going to have a milder course. But mutations in certain genes, if we can develop testing for risk factors for more aggressive disease, that would certainly help us decide if we need to be more aggressive with treatment early or if we need to just monitor an individual. So this table shows us that, again, the NOD2 CARD 15 mutation is an independent predictive factor for small intestine disease with narrowing and penetrating disease, or can cause strictures, fistula, blockage, and perforation. So a more complicated disease course. The mutation in JAK2 is also a predictor for more complicated disease course. The IL-23 receptor mutation is more associated with Crohn's disease susceptibility, and multiple genes, again, on this table can hint at the disease course. Currently, there's no clinically available single genetic test for Crohn's disease, and I don't think that we'll have a single genetic test that will tell us, okay, if you have Crohn's disease or ulcerative colitis. But the genetic testing that is out will allow us to predict how severe the disease will become, and will potentially allow us to decide what best treatment to use. Next slide. So in conclusion, like we've summarized, there's no single cause for inflammatory bowel disease, but it is a multifactorial disease that there's a close interplay between genetics, environment, infection, and diet. There's no one gene that seems to cause inflammatory bowel disease, but there are multiple genes that are affected in individuals with Crohn's disease and ulcerative colitis. There is an increased risk for inflammatory bowel disease in families who have one individual affected, and no single infection or dietary exposure or lifestyle seems to cause inflammatory bowel disease. So the one factor that we can clearly identify across all studies is that smoking increases the risk for developing Crohn's disease, and it reduces the risk for developing ulcerative colitis. So again, smoking needs to be stopped in anyone who develops Crohn's disease. Genetic studies have helped focus scientific attention on immunologic pathways that can be studied for future treatments and will likely determine disease severity. So I'll stop there. And Alicia, do you have any questions for me?
I do. Thank you. That was super interesting. And especially the genetics part just seems like a Pandora's box. Like it feels like we've just lifted the lid a little bit, but that really soon a bunch of, sort of research is going to come out of this. That's going to be really interesting for our folks with IBD. I want to back you up to kind of your first slides where you're talking about the how when people sort of tend to move to the United States, how their risk increases pretty significantly. Is that simply because of, do you think, I mean, obviously there's nothing simple about this, but does it have a lot to do with sort of diet, the sort of diet that changes with this sort of more westernized diet?
Yeah, so there's a number of changes that occur when an individual is growing up or living in the developing world versus when they move to the United States. So firstly, the bacterial mix that they're surrounded by will change. So it may not be that there's a single bacteria that is causing their inflammatory bowel disease, but the immune system that they had when they were living in, for example, India, was attuned towards balancing the bacteria, the viruses, and the fungus that are in their environment there. So that immune system is monitoring for those bacteria and pathogens that it was brought up with as a child. When you move to a different environment completely, and you're exposed to different bacterial or different microbiome, the immune system will potentially be disordered and be dysregulated. So that idea that the immune system is in constant communication with what's happening in the gut is the underlying disease site in ulcerative colitis and Crohn's disease. So there could be a change in the microbiome of, when we shift locations. Generally, the microbiome in an individual is pretty stable once they're a child into adulthood, but moving to a new environment, being exposed to different foods, being exposed to different antibiotics can shift that. So travel to a new environment can be one factor. The food stream is completely different in an industrialized environment as well. So, our food is much more fat focused, much more processed carbohydrates focused. And there are multiple studies looking at, and I think Dr. Fegans probably hinted at this, multiple studies looking at what in the food stream could be triggering inflammatory bowel disease. Mm-hmm. So it may be that in the industrialized countries, because we have more processed foods and the preservatives that are in the foods, or it may be the fatty acids or the fats that we're actually using are more inflammatory. So certain fats can be pro-inflammatory and cause activation of certain disease states. Not a single one has been identified as a single cause, but the mix is entirely different in the Western environment versus the environment that the individual grew up in. And then the other factors would be the preservation of our food, refrigeration of food, and processing of food is completely different. So it may actually be that there's any one step in that system could be a trigger for it. We don't have a single cause. And then in terms of industrialization, we also think about, okay, there's potentially more pollutants and air pollution, but there is cleaner water and increased hygiene. So it's a very difficult question because this is we at the very minimum we can find some genetic factors that are fixed between individuals, but we can't really pin down the diet or the microbiome or their environmental exposures as well.
Yeah, you're right. I mean, there's so many factors at play. It's hard to say, okay, this is the factor. I am curious though, because I know in some other autoimmune conditions, when you move actually plays a part in sort of changing your chance of getting it. So for instance, in multiple sclerosis, if you grew up in a sort of more northern latitude, you have a higher likelihood of getting it. But if you move south in enough time and you're in a lower sort of closer to the equator, then it changes. You sort of go back to having the same level of risk as the people that are in that particular sort of area. So is that also the case for IBD?
There seems to be some north-south polarity there. There's a lot of immunologic overlap between multiple sclerosis and inflammatory bowel disease, so we do see a similar trend there. And then we do see that following infections, following some acute trigger, you will go on to develop, for example, some individuals will develop psoriasis immediately after having a certain type of infection, or in related disease called ankylosing spondylitis or spondyloarthropathies that are inflammatory diseases of the spine and the large joints. It can often be triggered by a urinary tract infection or by a gastrointestinal infection. So we know that the activation of the immune system is probably the the snowball effect is started there, and then once it starts to go down the hill, where it's out of control. But what causes that snowball to build up is a number of these factors, and in a susceptible individual.
Got it. Yeah, and then who shoves it down the hill? Sadly. Okay, so in the genetic marker slide that you had, I think it was probably third to the end here, you mentioned that there are some tests out there that we are able to look at sort of genetic factors. And if you see sort of those factors in somebody's genetic makeup, that we are able to maybe potentially change things. Is that true? Are we really being able to do that? Because that seems really exciting.
Well, what we've been able to identify is genes that are highly associated with development of Crohn's disease or ulcerative colitis in a very small population of individuals. So the genes that we can identify and name are only accounting for the disease in a minority of individuals. So if we look at 100 people with Crohn's disease, ulcerative colitis, if we tested them for a NOD2 mutation, it'd be very unlikely that we're going to find even one of them affected with the mutation there. However, if we take someone who we know has NOD2, we certainly know that they're going to have a more aggressive disease pattern. So what we hope to do is that that one mutation is probably associated with multiple processes in the immune system. And so what we hope to find is that there's a certain pathway or a certain aspect, a certain focus of the immune system that we can hopefully test and identify that if you have a problem in the in one area of the immune system, perhaps related to the way that our cells absorb and bite into bacteria or eat bacteria called autophagy. If we identify mutations in that pathway, then we can say, okay, there's going to be a more aggressive disease course or a less aggressive disease course. Or if we see that there's just something in this trafficking or the way that the immune cells actually move through the immune system, that it would be a less intense disease course. So this is not quite ready for prime time. There are, again, about 200 genetic loci that are identified. And what's happening now is that they're refining that. There's ongoing studies for different race population, different ethnic backgrounds, and trying to get a better understanding of the genetics. We'll probably have quite a bit more information again in the next 10 years because it's been an explosion of data over the last 20 years.
Yeah, well, and it's the sooner the better. I mean, it seems like being able to really be more aggressive with those folks that, with the treatment, not obviously the people themselves, but be more aggressive with your treatment with folks who are showing those, that genetic predisposition to have a more aggressive course certainly seems like it's something we should be doing. Staying with genetics for just a minute. So a lot of these studies were looking at either having like a twin or a first degree relative with the disease. Has there been any studies for people who maybe have two family members, like maybe both parents have like inflammatory bowel disease? And what does that increase your risk even more? Or does it still sort of stay at that sort of tenfold increase?
Yeah, so for having, one moment, I think I have I have that as an answer if you give me just 1 second here. For having two parents who both have inflammatory bowel disease, that does put you basically at the highest risk situation for developing Crohn's disease or ulcerative colitis yourself. But that's still, it's not a total, it's not a totally genetically driven issue. Let's see here. So for having both parents affected, if you give me 1 second, I can find that answer. I think it falls under 3% is what I recall. I'm just kind of off the off the cuff, but it's not a guarantee. So both individuals, if both of your parents have ulcerative colitis, Crohn's disease, it's still less than 5% chance that you're going to go on to develop Crohn's disease. So it's it's much higher than what it is in the general population, because the general population, Crohn's disease and ulcerative colitis are rare diseases. But when you do have that two factors increasing your risk, it does put you at higher risk than the general population.
So I think I actually asked Dr. Figgins this question as well, but so say you have somebody that comes into your office and they do have a family member, like maybe a parent with inflammatory bowel disease, and they're developing symptoms. Do you, by default, perhaps treat that person a little more aggressively just because there is that sort of, possible family history?
Yeah, I absolutely do. So in my practice, I take a detailed family history. I try to go back at least to the individual, their parents and their aunts, uncles, cousins, and their grandparents to try to see if there's any inflammatory bowel disease, but also colon cancer. There's an increased risk for colon cancer and chronic inflammation of the colon. But there is one thing that we didn't look into on this talk, but there's a lot of clustering of other autoimmune diseases like you're hinting at. So ankylosing spondylitis, psoriasis, rheumatoid arthritis, type 1 diabetes, celiac disease. These are all autoimmune diseases. And if you have increased risk for having multiple of those, there is an increased risk for inflammatory bowel disease in those families. So I take a pretty detailed history of all of these autoimmune diseases. And if someone comes to me who doesn't have an obvious, case of bloody diarrhea, but they have some symptoms that could be hinting at Crohn's disease or ulcerative colitis, I'll certainly be more aggressive if they have a family history that's suggestive of autoimmune disease.
Yeah, I think that makes sense. The one study that was really interesting is the British study you were talking about. I had a few wow, interesting moments on that one. But I'm curious. So the one where the twins that were taking pills, the over the contraceptives, that was super interesting. So do you have does that affect how, if you have a female patient of childbearing age in your practice that has Crohn's disease, do you generally have them not take oral contraceptives? Do a different form of contraception?
So I don't change their contraceptive practices. I think that what we see is that it's a risk factor for Crohn's disease statistically. However, there's a number of things that we could be underlying the cause there. It may be that those those individuals have the drug itself could be causing it, but it could also be signaling some other factors. So somebody who is chronically sick with a gastrointestinal disease may want to be on oral contraceptive pills. So it may actually be, not causally associated there. So I don't stop it. Certainly, we know that there's higher rates of clotting, so deep venous thrombosis and pulmonary embolism in individuals with active severe Crohn's disease, ulcerative colitis. And that can be increased even higher if they're on oral contraceptive pills, and then even higher than that if they're smoking. So I strongly advise my Crohn's disease patients to stop smoking. And if anyone has a history of clotting, then we're going to have a detailed conversation about what sort of birth control they should use. And there are, safer approaches than a standard hormonal oral contraceptive pill if they have a risk of clotting. So I didn't find any clear explanation as to why that would be, a risk factor. We certainly have individuals who say that their disease is hormonally, driven, and they'll have more disease at certain times where their hormones are changing. But I think that's an individual case-by-case situation.
Yeah, interesting. You mentioned smoking. So the other question I had again goes back to if what they were looking at is really smoking from the person who had the
Right.
disease, but were there any increased risks for Crohn's disease or ulcerative colitis if you grew up in a household with
So
smoking?
that was what we call passive exposure or secondhand exposure. There's been some studies that show that may be a twofold increased risk, but those are really difficult studies to do. We know that if you're an individual who does smoke yourself, it's about a fourfold increased risk for development of Crohn's disease. So I think that there is some linkage there, but that wasn't specifically demonstrated in this study.
Okay. As a child of the 80s and late 70s with, no seatbelts and smoking, I guess it's good to know that maybe it's not as bad as I think.
Right, and that's another feature of industrialization, modernization, is exposure to smoking and tobacco. So that may again be why there's certainly some higher rates of inflammatory bowel disease in individuals who move to the westernized countries.
Yeah. Very good. Well, I think those are all of my questions. Thank you so much. This is really, really interesting. And I know that there is more research coming out very soon. I know, for instance, the Crohn's and Colitis Foundation has funded research in the pediatric world around pediatric Crohn's disease and sort of looking at genetic factors that might increase, like exactly said, a more aggressive disease course. And I think they got some really great results from that when they were able to really find some interesting things. And actually the next step that they're looking at right now is looking at an actual instrument to be able to test the genetics of these kids. And so, fingers crossed that we're able to, that's something that can be developed that could help direct the course of these kids with Crohn's disease. So I think if that's happening on the pediatric side, I know we're getting close on the adult side as well. So I will keep my fingers crossed.
Yeah, absolutely. Well, thanks for having me. Thank you.
Yeah, thank you so much for doing this. We really appreciate it. And everybody, you'll have a chance to ask questions. I'm going to give my information on a slide at the end of this presentation, and you can email me with any questions that you may have for Dr. Fegans or Dr. Trivedi. So thanks, everyone.